Okay. Hello, everyone. Welcome to another session of DentalShadowers. And today we have Dr. Kats with us. And Dr. Kats, thank you so much for taking your time to meet with us. And whenever you're ready, you're free to take it away.
Okay, great. Hi. Welcome everyone to my house. I'm Dr. Kats. I'm a general dentist. And a little bit about me. Just kind of move the photos over. This is my journey to becoming a dentist. I didn't start out wanting to be a dentist. I'm an immigrant from Kazakhstan, the former Soviet Republic. My family moved here when I was 10. And I started out as an art major. I wanted to be a jeweler. And then all of a sudden, sophomore year in college, I decided I did not want to be a jeweler anymore and randomly chose dentistry, completely randomly, without only having gone to the dentist. So I switched, took all the science courses, all through summer classes, and in about 2 years, got all my pre-dental requirements done, took my DAT and applied to Marquette University School of Dentistry in Wisconsin. So I'm from Milwaukee, Wisconsin, and it's the only school I applied to. I don't recommend that. I think I just got lucky. I didn't realize how difficult it was to get into dental school. So don't do what I did. Apply to more than one school. To study for the DAT, I don't know if you guys are familiar with the DAT exam. It's just a placement exam to get into dental school. It scores you on science, math, but it also places a lot on spatial differentiation. So being able to figure out 3D objects in your mind, and not a lot of people are good at that, and dentists are inherently good at that because that's just how we work. We work by almost blindly sometimes, so you have to know what's behind an object. Be able to picture it in your head. Yeah, that's my journey to dental school. Nothing exciting. It's not like I wanted to be a dentist my entire life. I don't have any doctors in my family. They're all engineers. Let's see. So this is kind of, apply to more than one school. Don't skip the visual prep, even though it seems like it's going to be easy. If it's not your strong suit, definitely brush up on it and study it. And when you are doing your interviews for dental school, who you are and your personality matters more. I became friends with a lot of the admissions people, and I'm in the same study clubs with people who do admissions at Marquette University. So I tend to chat to them about what it is that they look for, like what are they looking for in me when I accepted me to the dental school. They said most everyone that applies to dental school is really smart. So they expect people to have good grades. That's normal. They want people to have great personality, be able to communicate well, and just be humble and be able to learn and admit mistakes and things like that, because that's all dentistry is. You're always going to be learning. Yeah, they all know you're all very highly qualified, otherwise you wouldn't be applying. So a little bit about general dentistry. I don't know how much you guys are aware of what I kind of went into the basics. I'm not sure if it's going to be too basic, but it's fine. I mean, general dentistry is you're able, as a general dentist, you're able to do whatever it is you think you're good at. So any part of dentistry you're able to do. So as long as you've learned the skill and you think you can do it at the standard of care, and that's important, then you're able to do it. Anything from basic fillings to crowns, veneers, bridges, placing implants, periodontal surgery, removing teeth. I tend to organize my schedule in a way that it flows well. I don't like to have too many heavy procedures one after the other, so you can have a little break in between. But sometimes it happens. Sometimes you have a lot of stuff right after the other. But in the end of the day, if you own your own practice as a general practitioner, you can shape it in any way you want. I've seen general practitioners have a primarily orthodontic practice, even though they're generals, or sleep apnea practice, even though they're general practice practitioners, or they only do crown and bridge and cosmetic work. So you don't have to specialize in a particular field in order to only do those procedures as a general practitioner, but you have to be good at it. You can't just, just say you're a cosmetic dentist without having done the training, things like that. As an associate, it's harder. So there's different ways to be a general practitioner. You can own your own practice, you can be a partner in a practice, or you can be an associate. When you're an associate, you work for someone else. And as you guys know, if you've had jobs working for other people, you kind of have to do whatever they tell you to do. So you don't really have many choices in the type of equipment that you have, the type of procedures that you do. I mean, you're not going to be forced to do procedures you're not comfortable with, but you're not going to be able to choose things very well. Sometimes you're lucky and you find an associateship that gives you more freedom, but it's not common. But they're good. I was an associate for over 10 years before I owned my own practice. So it builds up your skills and confidence, and then you learn what you like and don't like and how a practice is run, which is also helpful. What kind of complaints do the patients present with to the clinic? I mean, your typical toothaches, lost crowns, broken teeth, broken fillings. Those are just your average, what we call bread and butter dentistry. Then there's the muscle and joint pain where they think it's their tooth that's bothering them, but it's actually the muscles. So you have to figure that out. Just your regular checkups and cleanings. That's the majority of the people that go through the practice. Swellings and infections, those are more rare, but it's nice to know how to treat them and if you need to drain them so that they don't go out of hand. Replacing missing teeth with either bridges, implants, or partials. Fixing or replacing old and broken prostheses like dentures and things. Cosmetic reconstructions, if somebody has really worn teeth or broken down teeth, being able to put them back together. And then airway growth guidance for children and adults. So this is becoming more referred into my practice, as in people are figuring it out that I do this. So I see kids early on to figure out where their restrictions are and guide them to growth. And cosmetic tooth alignment, as in like braces, ortho, things like that, or expansion. Kind of what people come in for. Diagnostic tests and instruments. So it's varied, but it's almost always kind of the same. Every time you see a patient, it's almost like a puzzle. The most important instrument you have is your ears. You kind of want to listen to what they have to say. Most of the time, they would have either had that complaint for a very long time, and if you just take the time to listen, you'll be able to connect the dots better than someone who just told them what was wrong. Have a lot of anxiety about it. So if you take the time to listen for 10 or 15 minutes, that really removes a lot of their anxiety. They think that you care, because you do. They're in good hands, and then they're more likely to let you do whatever that it is you're recommending. But we use things like digital x-ray, BCTs. Digital cameras are great. They're super inexpensive now. You just take a picture of a broken tooth or whatever's wrong, and people get to see it for themselves. And I no longer tell them what needs to be done. I just ask them, what do you think? I show them a broken tooth or a bad filling, and I just say, this is what that tooth looks like. What do you think? And more often than not, they go, yeah, that looks pretty nasty. And I go, yeah, that's true. What do you think we should do? And then they'll just lead you to the answer. They go, oh, maybe we should do something about that. Okay, do you want to know the options? So it's very open-ended, and that way they don't feel like you're pushing them into things, and they're still kind of agreeing to treatment that's better for them. Without being tricky, I mean, they're kind of choosing it on their own, but then they don't feel like they're being sold dentistry, which a lot of people think that dentists just are out there selling dentistry. But digital cameras are fantastic. We do cold testing to test the vitality of the nerve. We tap on the tooth. I mean, just your basic things that really figure out the condition of a tooth. We use a thing called a tooth sleuth. You get to bite on it, and if a tooth is cracked, it will hurt when they let go or when they bite down. If it's fully cracked, it hurts when they bite down. If it just has a small fracture, sometimes when they let go, it hurts. And then we use many other like specialty instruments to test things like an electric pulp tester. The endodontists have that, and it's pretty nice to test the vitality of the tooth. And then other instruments we use are just like our handpieces. That's just the thing that we use every day to work on the teeth. And lab equipment, like digital equipment, things like that, printers, computers. I mean, we use computers a lot more now than before for digital analysis and planning. And this is just some examples of some of the things that we use. So like the digital camera, I have it all the time, either recording things that I'm doing, the process of it, or just mainly to communicate with people. I tell them that I take the pictures in order to show you what I see, because otherwise using words, it's really hard to describe. You'd have to go to dental school to figure it out. So I just show them the pictures, and usually they can follow really well. These are the 3D scanning images, digital design, like a wax up almost. This is the cold test here, vitality test, the electric, and then the digital x-ray or Panorex. New technologies that are coming out in general dentistry or in dentistry overall are digital impressions. They're great. And then using digital impressions to send to the lab almost instantaneously. They design the crowns for you digitally. They send them back. It's great. Instant communication. You can do diagnostic wax ups. Like I just showed you on the previous slide, you can test things out, see if it'll work with their bite. You can change it quickly. I was never good at waxing with wax, so I am fully taking on the digital wax ups. It's much easier for me, and I can do it much faster than by hand. You can, some people even have mills in their office. I don't have one, just don't have the space. But you can have a scanner and then right away on your computer design the crowns or onlays or things like that, and then mill them in the office, and within a few hours the patient can have their crown instead of coming back a few weeks later. That's convenient, and it can be a selling point for a lot of people. There's new things coming out where we plan people's cases or smile designs using their entire face, as opposed to just like the smile or just the teeth and how they line up. So there's 3D facial scanners that scan the whole face and how the teeth go into that, and merging those with the CBCT. That's pretty cool. So you should be able to plan an entire case all the way to the end, and then kind of back work the workflow, which is kind of neat. So you can catch where the mistakes could be made before they are made officially in the person's mouth. Something that I'm doing now is I'm scanning people's teeth in, and I'm digitally designing what a perfect smile would look like in their face, and then doing a try-in, just so they can see what they would look like if they had the smile they've always wanted. I don't charge for it, and people just kind of like they've never imagined themselves, if someone has really crooked teeth or really broken teeth and all of a sudden they see themselves with the smile they've always wanted, it really changes their perspective of what's possible. And sometimes they're just more likely to go ahead and go through with what's necessary to get things done. So that's cool. You can do it analog. We call it analog and digital. So you can do all of that analog. Just for me, it takes 10 times longer than if it was digital. So, and this is some of the digital things that I was talking about. So there's 3D printers. You can print dentures, custom trays. This is a surgical guide for implants. This is a partial, kind of not wax, but they can melt this and then cast metal for a partial framework. This is an occlusal guard. This is a temporary bridge. And I think they're working on 3D printing semi-permanent bridges, like composite. That's cool. And then this is like the inside of a denture. This is a scanner. The one on the lower left, that's the 3D planning using the entire face, which is kind of neat, where the teeth will go in the face and in the head. And this is the smile try-in. So something you can put in someone's mouth and then they can see themselves with their smile completely changed, which is kind of neat. Important terms in dentistry. I don't know if this is going to be too basic for you guys, but just like tooth anatomy, enamel, dent, and pulp, you know, once you learn it, you think it's basic, and then you realize the patients don't really know what you're talking about, so you have to dumb it down. But diagnostic terms like necrotic, irreversible pulpitis. I was told in dental school not to use the term dead tooth. That's what patients understand. It's really hard to, like, it's necrotic. They go, what? Well, the tooth is dead. Oh, okay. I don't know. I don't know why they told us not to. Maybe people don't like the word dead. Periodontal disease, you kind of have to describe everything. But now we have videos. I'm a member of Spear Study Club. I would highly recommend you guys look into that. I don't know if they have a pre-dental section for you guys to be able to use their educational platform, but Spear, S-P-E-A-R, .com, or is it speareducation.com? Yeah. Anyway, they have, if you're a member of their study club, you get to use patient education videos, and it's fantastic. They're 1 to 2 minutes long. I send them as emails to patients after their exams if there's something I want them to learn more about, and it just explains all of these more complicated terms to them, and it's really great. They're also on my website. Like, if you guys want to know what those are, you can go to my katsdental.com. The link's on the end. You can see what those videos are all about. Malocclusion, that's just kind of like how the teeth bite together, right? And then different type of dentists, general dentists such as myself, oral surgeons, periodontists, orthodontists, radiologists, pediatric dentists, endodontists. So radiologist is like a new form of, you can be a dentist and then specialize in reading CBCTs. So that's kind of a new field, which is nice. Just a different way to practice dentistry. Pediatric dentist, endodontist, oral pathologist. It's just another kind of cool way to practice dentistry without using a handpiece. Let's say something happens or whatever, you can always specialize in that. There's always options in dentistry. If you have a dental degree, you can always teach. You know, if you have, the field is pretty big. So even if you can't, if you become disabled or whatever, but you're still able to, you know, think through treatment planning, there's actually companies like Digital Smile Design, they'll hire dentists to treatment plan cases for them, which is nice. So if you're really good at figuring out puzzles, but you hate the physical part of dentistry, or you end up figuring out that, hey, this day-to-day dentistry is not my thing, there are so many options in dentistry outside of clinical work. So just so you know. I wanted to go through a couple of cases. This is actually my son, not the tongue part, but the pictures on the left. That's my son. This is how I got into airway diagnosis and treatment planning about 3 years ago. So he's 6.5 now. These pictures look kind of strange on here. I'm sorry. Anywho's, I thought they fit in better. 3 years ago, I figured out something was wrong because he wasn't breathing when he was sleeping, and the pediatricians weren't really all that concerned. And so I kind of, having gone to multiple courses on adult sleep apnea, I connected the dots and I said, wait a minute, my child has all the symptoms of an adult who can't breathe at night. And, you know, he's only 3.5. So I was able to get him seen by an ear, nose, and throat, got his tonsils taken out. And then in the last few years, I've learned, like, just binge learned airway and early growth interventions just so I can help him. And thankfully, I got into it early enough to be able to help him. So I just finished his expansion, and he's completely symptom free now, which is amazing. So we had, this is kind of an outline. It's covered up by the photos. I'm sorry about that, but we had his tonsils removed. We had his tongue tie corrected with functional therapy after that. And then I did his expansion of the upper jaw, lowered, and then protraction using headgear, which is not really normal right now for 5-year-olds to be able to do that, but I think this is a great time to do it because that's when the bone is the softest and you're able to get growth really quickly, so they don't even have to wear it that long. And they're incredibly cooperative at this age. They'll just do whatever you tell them to do, which is so nice. Much better than the teenagers. So, so this is kind of an idea behind what, I'm not sure why these pictures don't look so great, but before the age of 8, if you can get a kid before the age of 8 or 9, before their growth has slowed down quite a bit in the maxilla, you can get amazing expansion, increase the nasal volume, allow them to breathe easier through the nose. Once you do that, and then you create room for the tongue to sit up and forward, you really create a good setup for a lifetime of better breathing. So this is just kind of little things that show what the expansion does. It separates the suture, the midline suture in the maxilla, it separates it, and that way grows the nose as well, and creates some tongue space here. And then you can see how narrow this upper jaw is as compared to the lower jaw. You really want it to be on the outside. The upper jaw always to be on the outside. This is what we call a skeletal crossbite in the airway world, where to a lot of people this looks normal because the upper teeth are sitting on the outside of the lower teeth. But if you were to look at the bone itself, the upper maxillary bone is actually on the inside of the lower. So it's too narrow. So you have to expand. And these kids have a lot of symptoms like breathing, ADHD, nighttime sweating, peeing the bed way later than they should, maybe 8 or even 9 years old, snoring, grinding their teeth, things like that. So this is him getting his lower aligners. They're excited about it, and the upper finished expansion. So yeah. So another case is so the general dentist, you just get to jump from one to the other. So this is the implants. I did not place these implants. I had a periodontist place these implants, but this is someone who came in with completely failing teeth, just rotted out, decay. Great bone, great, okay gum health, good enough. And then these 2 implants here I had actually placed 4 or 5 years previously at another practice when I was practicing there. But I wasn't placing implants at my current practice. So I had the periodontist do these, which is fine. You kind of have to know, like, is this going to be too difficult for me, placing 4 implants that are that far apart with an aesthetic zone? Is that something I really want to put my name on, or do I want to have the periodontist do that, who does them, like, I don't know, day in and day out? Sometimes you just have to refer. So this is kind of, when you have a hairy case, you reach out to everyone you know. So I went to the Spear Study Club. I sat down with the prosthodontist that's in my study club, the periodontist that's in my study club, and a bunch of other dentists, and we just brainstormed. What are our options? What can we do? Which teeth can we keep? Which teeth can we not keep? What can we replace? Where do we put the implants? What do we think the function will be? And you just talk it through, and you pick whichever one will do the least dentistry. So you pick the solution that's going to hopefully do the least amount of invasive things to the patient. And that's kind of what we went through with her. This is me preparing for the periodontist to be able to take these teeth out, because I was changing where the gum was going to be. I ended up keeping this tooth and keeping this tooth just so she can have a long span bridge to wear while these implants were healing. I cut these teeth down and I contoured the gum. So when she goes back to the periodontist, they're able to know exactly where the implant's gonna go. And this is kind of showing it again, just kind of shaping the gum where I want it to be. Not the best temporary bridge, but we remade it later. It's very temporary. And this is one of we restored the back implant bridge first to give her stable occlusion and allowed the front to heal a little bit better. And then these are the front implants kind of during healing. This on the right-hand side is an example of a custom impression coping. I don't know how familiar you guys are with analog implant impressions, but when you're doing it, this is for the anterior, for the front teeth. When you're doing a front tooth impression and you've already taken the time to shape the gums using a temporary bridge or a temporary crown or something that really shapes the envelope of the gum, you want to transfer that to the lab quite easily. And the best way to do that is to make a custom impression book. And this is an example of that. And this is kind of like the end result of her implant completed. She liked it. She wanted really white teeth. I don't love it. So I wanted them to be more natural, but you kind of do what people ask for. This is an example of another airway expansion case. So you can see how crowded this child is. He's 16. And this is a classic tongue tie patient to me. When I see someone that's that crowded and that narrow in the face where the teeth are, just super narrow, I always wonder how restricted is their tongue. And he's extremely restricted. So that kind of restriction allows the tongue to kind of hang out at the bottom of the mouth when it should be stuck at the top. And that really strong tongue muscle is the main growth guider for the upper jaw. That kind of upward and forward push of the tongue when it's not restricted allows for the upper jaw to grow wider and more forward. And when the tongue is restricted, that's kind of one of the comorbidities of crowding and a really narrow face and mouth breathing, things like that. So classically in a child like this, you would try to unravel, but classically people would take out those premolars and try to line things up because it seems like the easiest thing to do, right? He's a good looking kid. You're not really going to change his face. That's fine. But what you're not going to do is you're not going to undo the growth issues. You're not going to improve his breathing. You're not going to give him any more tongue space, right? So you're not going to make him worse than he is right now, but you're definitely not going to set him up for a healthier lifestyle later. So for someone who's 16 like this, the best thing to do is to use implants with a maxillary skeletal expander such as this on either side of the maxillary suture. I mean, the best thing to do is to catch this kid when they're 4 or 5, and then you're good. But if you've missed the boat, that's fine. Even up until the age of 40 or 50, we've got options. You know, they're just different options. So for a 16-year-old, you place this expander with 4 implants, 2 on either side of the palatal suture, and you crank it 4 or 5 times a day. And it breaks the suture and it creates a gap. And then it grows the jaw. And once you've grown the upper jaw, then you can unravel the lower teeth to fit into the upper. And now you've got a wider, bigger smile, more space for the tongue, easier breathing through the nose, and just all the room you wanted for the teeth without any extraction, which is nice. So sets this kid up for a healthier future. And this is kind of the planning of this case digitally to see where the bone is, if it's too thin, if it's too thick, how likely it is to work. This kid's bone is a little thin in the palate, so we, once we do it, we'd say, it's possibly might have to go a little slower with you. Instead of 4 or 5 turns a day, we might have to do maybe 2 turns a day because we don't want those implants to walk through the bone because it's so thin. And plus it increases the risk of it failing and not working. And then you're looking at some kind of a more surgical intervention to break that suture. And my advice for future dentists, I would say you can't help it because you always have to learn new things in dentistry because, man, they're always coming up with amazing stuff. But just to never stop learning. You think you've graduated school and you're like, oh, I'm on top of the world. I'm a doctor now. Fantastic. But like the bare minimum of what you need to practice dentistry, the bare minimum. You know enough not to like hurt anyone too badly, but you don't really know enough to really prosper and to really help your patients. So keep learning, always realize that you may not know all the answers and someone else might have more answers than you, and be willing and just not. The best thing to do in dentistry is not to have a big ego and to realize that you might have been wrong 10 years ago, but what you thought was the right way to practice, which is always true. I feel like that's all. If I look back at for each 5 years that I've practiced dentistry, I realized, why didn't I know this? Didn't learn it then, but I learned it now, and that's okay. So know better, do better, right? Okay, that's it. Any questions?
Yes, we have a few in the chat.
Sure.
They're good. And the first question is, the office mills can be used for any crown or bridge, or is it only few specific cases?
The office mills?
Yeah.
Oh, yeah, sure.
The in-office mills.
The in-office mills right now, as they are, can be used for a number of different things. So they come in these little, what do they call them? Or whatever they're called, like little nuggets, right? So of different materials. So it can be a composite material, so you can mill out like composite stuff, or temporary, so you can do that. Some people even mill out like muscle relaxing jigs. It's cheaper stuff, nuggets. But a lot of people do crowns, like single crowns, simple bridges, inlays and onlays, like a simple porcelain caps, not like a full-on crown. I think mostly they're used for that, but you're starting to see more mills incorporate things for implants. So you can do like a custom implant, that, like not the implant itself, but like the temporary or whatnot, or like a custom healing abutment or things like that. So I think they're developing more things for the mills for sure.
Got it. So with nasal expansion, how would you go about closing the teeth gap afterwards?
Yeah, it's actually, I had one expansion done and it's almost closed. You just do Invisalign. It actually closes really easily because the fibers between the teeth, they don't really want to let go. So if you just let it go, they'll probably just close on their own. The only thing is, let's say someone like me who had perfectly straight teeth before expansion, now I have all these gaps in my teeth because of that. Then you just make the teeth bigger later if you want to, or not. I mean, whatever. I don't care. But see what my dentist tells me to do. But usually when you need expansion like that, people have a lot of crowding. It's not that their teeth are too big for their mouth. It's just that their mouth never grew. That's like the new airway functional centered thinking, at least in the circles that I'm in. There's no such thing as too many teeth for the mouth. It just never grew. And why didn't it grow? And how can we prevent it from not growing early?
Got it. For the last case, would you mind repeating why we expand the upper jaw first?
Great question. For the teenager, right? So when you have someone who's a teenager and adult, you expand the upper first because you want to make sure it actually does it. In a child, you would unravel the lower first, so you have that guidance to tell you how far to expand the upper. In a child, it's guaranteed to expand, no problem. And an adult, you're not sure if it's going to work. So you just want to make sure you're actually getting expansion, you maximize it, unravel the lower, because in an adult also, you're kind of limited how much you can do. Because the lower bone is not as flexible. You're only going to get so much done. And then the lower jaw can't really kind of auto rotate forward. In an adult, it's kind of stuck where it is, unfortunately. So it's just a lot of downsides to doing it as an adult. There's a lot of advantages that you can get a lot of things done, but much better when you're a child. Yeah.
Got it. What was one of your favorite things about attending dental school in Wisconsin?
In Wisconsin in particular?
Yeah, just in dental school. What were your favorite things about your dental school?
I loved my classmates. more than like dental school was hard. We had really good professors, just really good relationship with the professors. There was really we used to hear all these stories from our professors and mentors, like of all these hardcore dental, in Marquette, there's none of that. They're just all really nice. So even though dental school was super hard, we just had a really good community. And I don't know if it's just Milwaukee in general is like that with dentists. We're not very competitive, and Marquette University was like that. We're not very competitive. So I don't know if it's just Marquette is like that, so then it breeds dentists who are like that, or what, because we all kind of stick around in Milwaukee. So Milwaukee itself is not competitive at all. We're always helping each other out.
Got it. That's great. So someone says, I'm a bit confused, but would placing 4 implants in the mouth of a growing child be considered invasive? How did you draw a balance in that situation?
Great question. So current research about expansion, those are temporary implants. They don't stay. You take them back out. And they're really, really small. So they're the same implants, very similar implants to what you would use as TADs for orthodontic movement. Sometimes you put implants up here and up here to like help guide growth guidance and things like that, or to like move molars forward or backwards or whatever. So they're temporary. So keep that in mind. But after a certain age, 10, 11, 12, that suture is too intertwined. And when you put an expander in a teenager, all you're going to do is the teeth will move, but the suture won't split. So you're not getting that airway nasal volume growth.
Got it.
So the benefit of improving nasal breathing, and easier nasal breathing and actual physical growth of the palate is eons above the little implants that go in. And I have them down and they're not so bad.
Yeah. Got it. Someone said, is using the maxillary skeletal expander best suited for young patients? Are there any restrictions using this tool?
So yeah, of course it's better in younger people because the suture is not as closed. It doesn't ever close, but it just gets intertwined and harder to break, right? But there's tools that they're coming out with to help. So let's say in an adult like myself, I had it done at 39, right? So that's not the best age to do it in. But if you put the implants in and you put little, they're called corticopunctures, little tiny holes right down the midline of the palate, it weakens the intertwining and then it's able to break. It fails more often the older you get. Thicker bone, older person, different ethnicities are harder to break the palate just because of thicker or harder bone. If someone has a tori, like that big chunk of bone on their palate, that makes it harder to break. But it can be combined with other things. So there's things that are coming out, like the dome. It's called I won't remember what it stands for, but it's like a surgical way of like cutting the palate and like other sutures in the mouth to help expand. So there's ways around it. It just becomes more invasive the older you get. Yeah, it's much easier in a child or a teenager or a 20-year-old. Yeah.
That makes sense.
Yeah.
What would you say is one challenging thing about this profession?
Just one? Okay.
I know. The most.
I would say the main challenge is being too hard on yourself. We're all perfectionists. We all want to be really good at it. And sometimes things just don't turn out the way you want them to. And you end up being really hard on yourself. So the challenge is to not be too hard on yourself when things go your way.
Yeah.
Because you might have another chance to do it, or you've learned something from it. And in the end, there's very rare life and death situations in dentistry.
Yes.
So don't be too hard on yourself. That's the best part of the profession.
Yeah.
You can usually redo it if you don't like it.
That makes sense. And how do you balance work life and work and life? How do you find a balance between that?
I take way too many courses. My kids know I always have my ear pods in. Uh, I try. I'm taking them camping tomorrow. That helps.
That's good.
You just try. You just do your best because you really want to be good at what you do, and the only way to get good at it is to keep learning.
Yes.
But it takes a lot of time. So you just try to say, you know what, this weekend I'm not going to take any courses this weekend. I'm just going to focus on the kids or whatever. Or I'll read one article. That's it. Or you get the kids involved. They love it too. They still watch the courses with me.
That's good. I had a question actually. So about the implants, I know that both general dentists and periodontists can place them, right?
And oral surgeons too.
And oral surgeons. At what point does the responsibility, like if the periodontist was to place them, let's say, or an oral surgeon, at one point does the responsibility change into the dentist, and then the patient starts going in to see the dentist?
Good question. So a lot of the times you see people coming in to see directly to the surgeons to get their implants placed without seeing a general dentist provider. I don't think that's a great idea. Sometimes you get implants in the wrong place, right?
Yeah.
So it's best to always have a quarterback, and it's usually the general dentist or the prosthodontist, someone who's designing the case from the face and the body and whatever backwards. That kind of tells the specialist or works with the specialist, do you think this is the best place for the teeth? Can you make that work? What do you need to do to make that work? If you can't make that work, how can we modify the design? So there has to be really good open communication. This type of presentation I made for you guys, I actually make a lot of Google Drive presentations with my patients' photos and whatnot. And I just share them with my specialists and we just go back and forth. They go through my findings and my photos and my analysis and they go, yep, that'll work. Send them over for a consult. Or they go, I don't think that'll work. Let's consider this, this, and this. Before they even see the patient, they're already fully familiar with the case, which is helpful.
Yeah. So if, let's say the periodontist did everything up to the healing abutment, they can transfer over to the dentist, or like whoever starts the procedure has to end it.
There are some specialists that are like doing their own crowns, and I guess that's fine. I don't know if that's in their scope. State by state, maybe. I don't know. The way it doesn't happen in Milwaukee.
Yeah.
We usually just work as a team. That's just how we do it here.
Yeah. That makes sense.
I haven't heard of that happening in this area at all, but I've heard of it happening elsewhere. Yeah.
Okay, got it. That makes sense. Someone asked, how hard is it in your opinion? Oh, sorry, I refreshed. Okay. How hard is it in your opinion that dental school is to compared to undergrad? Coming from someone who majored in neuroscience.
Neuroscience, okay, that's harder than what I majored in. I never graduated undergrad, so that helps. It's harder because there's just way more stuff to do.
Got it.
You have to know how to organize your stuff. There's just, if you go from, let's say, 15 credits, or some people took 18 credits because they were really working hard, you go to like 26 credits or more. So it's a lot. And it's not only like the first 2 years, you're all didactic, plus you're doing lab. And the lab takes forever because you have no clue what you're doing, right? So, and you're there after hours and you're there on the weekends. You have no life for the first 2 years at all. But in the last 2 years, it's great because there's no lab. You're all in the clinic. There's hardly any didactic courses. They're all like dentistry focused courses. There are no like microbiology or any other crap. So, and you've already passed your first, boards. It's great. So the last 2 years are fantastic. I mean, it's still hard because you have no clue what you're doing.
Yeah.
And you're learning it all and everything's very stressful. And the first feeling you do is like, you're like losing sleep. But, if you're not losing sleep, then maybe you don't care enough. I don't know. You know what I mean?
Yeah.
So, you should be worried. If you're not worried, there's something wrong.
Yeah, definitely.
I love dental school. Would I go back and do it again?
No.
But I really enjoyed it.
Yes. Um, was it easy to find a job afterwards, after dental school, like in the area? How hard was it to find a job?
I never have a typical answer for this because the way I applied into undergrad and dental school was the same way I applied for a job the one time.
Mm-hmm.
What helps is if you put yourself out there and are friendly and are able to talk to people and you participate in like the protege mentor programs that they have or go to like the sport outings, just really have your face in places and be nice. Don't stand out as the person who makes life difficult for professors, things like that. So then your name is kind of known. I was like, oh, that's the nice person. That's like a good person to work with. And if you want to stay in the area, people will approach you. There's dentists retiring all the time. So I've had dentists approach me to buy their practice before I graduated, but I wanted to do a residency. So I did a 2-year GPR in Brooklyn, New York. So I wanted to get out of Milwaukee for a little bit. And then I came back and I ended up getting a job with my former mentor. He retired and he said, well, they're looking for a dentist. Why don't you work there? And it was like one of the best practices in downtown Milwaukee. And it was great. So it was a great opportunity.
Yep, that's awesome.
I think just even now, as you get older, don't burn bridges. The main thing is don't burn bridges. Be nice, communicate with people, don't spread rumor. I mean, just be a nice person and things will find you.
For sure.
Mhm.
Sorry. Someone said off track, but congrats on the NBA championship.
Thanks.
How do you feel?
About the piano, I don't know. I don't care about basketball. A friend had to close her practice because no one could park. That's the one who was the downtown practice because everything was going through the city.
Yep.
The
Can't
parade
even
through the city,
imagine.
she had to close the day.
Yep.
Well, it's fun. It's great. People are having a great time right now.
Oh yeah, for sure.
Yeah.
For sure. What was I going to ask? Oh, the GPR. Okay, so when you get into dental school and you're thinking about what you're going to do after dental school, how did you decide whether you wanted to do a residency or not, and how did you decide to do specifically one in like
a 1 or 2 year?
Yeah,
I
1 or
started
2
as a
year.
1-year residency. I decided because I was talking to one of the faculty on the clinic floor. And it was somebody I respected greatly, and he had a great way of like treatment planning, just really open and knowledgeable about emergencies especially. And I said, well, how did you figure all this out? And he said, oh, I did a GPR and I was on call and I hated being on call, but now I realized I learned so much more being on call than I did anywhere else. And I said, okay, well, what kind of residency do you recommend? And he said, do one in a hospital, not in a dental school, because you get the better emergencies. And you actually get to do a lot more dentistry for some reason. I don't know why. And he said, don't do a level 1 trauma. If you do level 1 trauma, you're kind of stuck being the oral surgeon's lapdog. You're doing all of their triage, but you don't do any of the work.
Got it.
So I picked a level 2 trauma hospital based residency that didn't have too many people, but just enough so you're not on call every day. Just kind of a sweet spot, and it was in a fantastic neighborhood in Brooklyn, like beautiful. So I kind of picked it for the location more than anything, but I really liked it, and I made really good friends while I was there, and I stayed a second year because I could finish my bigger cases, place more implants, things like that, periodontal surgery. So
yay, nice.
So you just get to do more things that you don't get to do in dental school, more advanced stuff.
Yeah. Like more experience
in things that you would not be comfortable doing if you had just left dental school.
Got it. That makes sense.
Mostly surgical and trauma cases. And you get to really figure out how a hospital works. Like people have no clue how a hospital works. So that was helpful.
Sorry, I had a question off the top. Oh, okay. Interview season is coming up, do you have any? I know you said just to shine your personality because that's what they want to see, but do you have any other tips for interviews coming up?
I guess they want to hear things that make you you. Like, why are you unique? I'm bilingual, Russian speaking, and there's a guy there who's still in my study club, still makes fun of me for that, but I listed Russian as my second language, and like burst out in Russian, test me. I'm like, Russian. So if you list a skill, make sure you can back it up.
Yes.
You never know who's sitting across from you.
Yep. Did you speak in Russian back?
Yeah.
Yeah. Okay, good.
But you never know.
Yeah.
He's a good guy. We're good friends now still. Yeah.
Great. That's awesome. And then any final words? I believe that's it for all the questions.
Okay.
Any final advice?
You guys feel free to reach out if you want to know like about more residencies. I have I mentor students at Marquette Dental School. I just have her someone who graduated this year. She's in her residency right now in GPR. She went into the residency because of our first conversation, our first mentor protege dinner. And I said, I loved my residency. And she was like, I'm going to do that. She was a freshman. And she's, having the time of her life, right? Yes. So things like that. Reach out if you want to know more about my experience or whatever, or anything else that I do. Feel free. I think I might have my, there it is. Sorry, my contact information.
Thank you. Thank you so much, Dr. Kats. We really appreciated your session. We learned so much about implants and general dentistry. And thank you so much again for taking your time out of your day to spend with us.
I loved it. I love talking to you guys. Good luck.
Yay.
Appreciate your time. All right. And okay, I think that's it for today. And the quiz link will be up in GroupMe, group chat, and Instagram, and also YouTube channel live chat. So check them out and finish them. And thank you again for coming out, and stay tuned, guys.